All right, so I'd like to introduce to you Dr. Betty MacNeill, who has been a longtime member of the HAPS family. She actually predates me, and that's kind of hard to do. So she's been around for 20 plus years with HAPS and runs several of our of our exercise groups, primarily in the South Sugar Land area and the west side of Houston. And so you've got fans in the back waving at you. So, Betty MacNeill fans. Dr. MacNeill has also been a professor at TWU for a number of, that's Texas Women's University, for a number of years. She is now retired, so she's giving lots of time to grandchildren and lots of time to HAPS, for which we are greatly appreciative. Please help me welcome Dr. MacNeill.
I guess I got a musical introduction as well. So we made, I don't know, two and a half years ago, this DVD. Hopefully you all have seen it, have had a chance to maybe pick it up at some point. There's a whole stack of them out there on a table. So please, we encourage you, because we did this specifically with the caregiver in mind. It is so difficult sometimes to take on that role of someone caring for an individual who's starting to lose certain motor skills. So we're going to be talking a little bit more about the motor challenges, especially in some situations. But I wanted to give you kind of a clue, and I do have a handout in there if you haven't pulled it out yet in your packet. I basically was thinking, you know, to take up the DVD and just watch it cold, you say, what the heck am I supposed to do with this? What's it all about? So I wanted to give you some recommendations for how to view it, and hopefully bring out the best utilization of this particular adjunct to everything else that you have learned. So, idea number one, view the whole thing from beginning to end. Don't take notes, don't worry about it, just get a sense of what is involved, because there's important information both in the introduction and in the conclusion about why we made it, who it's for, and certain key points of what you're watching for. But then what you would do is to go back and pick a particular chapter. So it's broken down into various segments of mobility challenges is how I review them. Watch it twice with your partner or client so that both of you are understanding what's going on. The first time you watch it, you're focusing in on the actual movements of the individual who's challenged with Parkinson's. Right, see what they're going through, see what they have to learn to do to perform a little bit better, more efficiently type of thing. The second time you watch the exact same chapter or section, you're looking at what the caregiver does. There's things of body mechanics, which is how you move your body in synchrony with another person. It involves maintaining a low center of gravity, being able to shift your weight and go from side to side or front to back. You basically orchestrate a movement with your client, with your partner. It's almost like a little dance that you may have to do to get certain movements to occur. So we wanted to go ahead, third point, I'm sorry, in what you're doing. Once you've watched a single chapter twice, you want to go ahead and practice that activity. Whether the individual with Parkinson's is having trouble yet with a particular task, that's irrelevant. You don't want to wait until they have trouble with a task before you practice a little bit, all right? You don't wait until you're on the baseball field to learn how to hold a bat, for pity's sakes, all right? So you want to be practicing even in anticipation. And preparation is key to success. I teach that to my PT students and to clients all around. You've got to think before you act, and this is one way of helping you to do that, I hope. Alrighty. Talked a little bit about what good body mechanics represents. Low center of gravity means bend hips and knees. The person that you're helping, you want to keep them fairly close to you. That doesn't mean you're hugging them tight or you're trying to pick them up. You're just maintaining a certain distance, and we're going to review some of those. And importantly, try not to do any twisting or torsioning to your back. You're trying to pivot through your feet rather than twisting through your spine. All right, so those are just some things. Because if you injure yourself as a caregiver, where does that leave you? And where does that leave your partner? All right, so you really need to kind of keep that safety. So biomechanics is about safe. So we're going to watch segment number 1, sitting up and lying down in bed. Interestingly, I found this interesting at least, this is one of the very first movement challenges that individuals with Parkinson's report having. Even before a diagnosis of Parkinson's is made, they may start complaining about, it's getting hard to roll over. I don't know, I'm just stiffer. I don't know what's going on. I guess I'm just getting old, as people often say. But this is a challenge that begins early on in the disease process and it only gets worse, of course, as the disease progresses. So you're looking to focus on certain segments. We focus on flexion when it's time to come up and down in bed. So you're bending the knees, arms going to reach to roll. You're going to kind of make a program or a plan of what this movement's all about. Watch what the caregiver does to assist with certain of these movements, all righty? And then I've kind of identified for you some of those key elements of what that caregiver is doing, spreading the feet and helping with the weight shift to get the person's body from the side to the vertical, all righty? So let's watch this segment. I think it's about 2 minutes, and we're going to check it out, and then we're going to talk about it once more.
One of the challenges faced by individuals with PD is that they have a hard time organizing their movements into meaningful patterns. The following techniques can be used to assist the individual in getting in and out of bed. Bend both knees up and roll onto one side. Pull the knees up further to bring both feet over the edge of the bed. Use both arms to push yourself up into a sitting position. Once fully vertical, sit a moment before standing or transferring to another surface. The individual should be close enough to the edge of the bed so that you can easily reach them, but not so close that when you bring them to sit, that their thighs will not be supported by the surface. Bend both knees up until the feet are flat on the bed. Reach across the top of both knees and begin to rotate the lower body towards you. Tuck your forearm under the individual's thighs and bring them against your hip in order to trap and control the individual's leg movements. Support the individual's upper trunk and head, if necessary, with your other arm by sliding it in behind the scapula. Start to roll the individual towards the side of the bed as you bring his or her feet over the edge by bending the hips and knees. Allow the individual to use his or her arms as much as possible to start pushing themselves up. You will also be guiding the trunk into an upward arc so that the shoulders are brought over the hips. To lie down in bed, the previous steps can be reversed. With the individual sitting on the edge of the bed, lift the feet onto the bed either together or one at a time. Assist the individual as they roll onto their side and move up, down, or sideways to get comfortable.
We just wanted to show one brief segment at a time, up and down in the bed. The amount of assistance that's represented on this particular video is pretty maximum. So we're basically saying trap the legs, bend them to get the feet off the edge, and then sit the person up. You can't necessarily see all the weight shift that caregiver is giving, unfortunately, but if you can imagine that I'm sliding the knees off, getting the feet down off the floor, sitting the person up, you saw that I move with the individual. So let's open the floor to questions, something specific that maybe you feel challenged by with your particular partner or client.
Okay, right here.
Yeah.
Okay, my husband, my partner, what if he weighs almost twice as much as you do, trying to, I see how you were, maneuvering, I just...
Okay, all I can say is you've got to use your body efficiently. Imagine that your arms are only an extension of your being, And they are not the primary things that are going to be lifting, pushing, pulling, doing everything else. I use the phrase trap the legs. Literally, if you have your arm around the knees, bring them right into your body. The arms are no longer working other than to stabilize. The movement itself is by the transition from one foot to the other. Now, this can be broken down even further. And one of the key things that hopefully the combination of the handout and then watching the video will do is that it gives you the steps that need to be followed. First, you want the lower body to rotate over. So I'm only operating half the body, so half the weight, and it's still supported by the bed. All right. So as you rotate over, then the upper body is going to follow. What regrettably is never shown completely clearly in this particular video segment is the amount of rolling sideways and backwards that the client was doing at this point in time. So it's always start on the side by rolling the knees, getting the upper body to come across. If you had to use both of your hands to take the legs over the edge of the bed, and again, my demonstration is saying shift your weight. It's not try to pick up the legs and bring them down over the edge, because that would get heavy for the caregiver, right? So it's always use your body, your arms are an extension, you trap with your legs. And once the feet are over the edge, it's remarkable how easy that upper trunk is to begin to right itself. Because with the feet going down, the shoulders naturally come up. Alrighty, I probably need to drop my paper here for a minute. Sorry about that.
Other questions?
I hope that helps a little bit. Okay.
I've got one here, Maggie, if you're not on the line.
Just a comment. We have one of those handles that you hook under the mattress.
Perfect.
So my husband's able to get to use it to pull up to the seated position.
Absolutely. That's fantastic. All kinds of adjuncts like that, and something I failed to write down, and I really should have. There are all kinds of assistive aids, if you will, like a grab bar in a bathroom. You can have grab bars on or under the beds to help you out with that. You can also ask for a home health visit, so that someone could come and evaluate your home and see whether or not positioning of certain furniture might be a way of helping the person in and out of bed, or utilizing different tools and aids that they may have available to you. So you can get some outside support and advice on looking at this as well.
Hang on.
Why is this side so quiet?
I'm curious about are walkers adjustable?
Yes.
Because it seems so often individuals are bending towards the walker.
Yes.
And then all of a sudden their body almost, it becomes dangerous. Mm-hmm. So is there an adjustment?
There are adjustments, and I probably follow one philosophy of how to fit a walker to an individual with Parkinson's. Someone else may have a different philosophy, so I'm going to discuss both of those if it's all right with you. As a walking device, what you're looking for is something that provides added balance. You're not necessarily looking for something that does a lot of weight-bearing support, although definitely clients with Parkinson's might need to bear their weight through the walker at times. The higher you put the walker, the less supportive it's going to be, because they can't ever use their arms to provide that extra support to help either bear weight or balance through the surface. Because that's what walkers do, it's what canes do. It gives you a point of contact with the surface that you use to add to your balance. So when you're fitting a walker, you want the arms, when they're pressing down, to be almost in full extension. When the person is standing with the walker by their hips, the hand part should be right at the hip bone itself. The easiest way to measure that, y'all stand up and do this with me, why don't you? Most of you have folks with walkers, or you're going to get there eventually, because this is one of the best ways to, well, I'm going to get there eventually. What can I say? I like walkers. They're kind of cool. All right. To at least start the measurement. Put the back of your hand right, oh, not my microphone, right on the top edge of your pelvis. Now drop your long finger down on the side of your leg. Okay? So top of your pelvis, drop the long finger. Alrighty? That is your hip joint. Well, the joint's inside, but you kind of draw a line. There's my hip joint, okay? You could literally, if you rolled your leg back and forth, there's a bone there, okay? So some people can feel it, alrighty. So if you can get the person to stand, you want the handles of the walker to be right at that point that you just measured, alrighty? On their hip. Y'all can sit down now.
Question about mattresses.
Okay.
Yeah, thank you.
All right. But that's the starting point. And then the next point is, as they begin to walk with the walker, do their arms give you anywhere from 10 to 20 degrees of extension? That's the starting point. Everyone might need a little extra help. And some people would argue, or a little bit extra height. Some people would argue, well, if I've got it so low, doesn't that add to their bending down? What adds to the bending down is having the walker too far in front of you. It has nothing to do with the walker height. I could make that walker as high as possible, and if they got that walker too far in front of them, they're still bending down. So here's my trick, because a higher walker does not necessarily make the person stand taller, because they lose their arm support, okay? The higher it goes, the less I can use my arms, okay? The key to trying to get your partner, your client, whomever we're dealing with, to walk better with a walker is to tell them to keep their hips inside the walker. Here I am. Keep your hips inside the walker. And then it doesn't matter where their feet go, because their feet have got to just stay with the walker itself. Keep the hips inside the walker. Alrighty. Is that easy? No. But sometimes it's a little bit easier than saying, stand up straight, stop bending over, stand up straight, okay? Which is what we tend to do because that's what we see. Try to put things in language that are a little bit more, I don't know, practical or meaningful to what they understand their movement to be. All right. We got way off track. But
Yeah, Betty, I think that there's there is a question over here about bed.
Question about mattress.
Last question.
Yes,
and then we
do
got
you
to
have
move
any
on.
advice on choosing mattresses and other, like, sheets, pillows, that type of bedwear?
I really do not, and I'm not that great at understanding. Now, clearly we would say the firmer the surface, the easier it is for the person to manipulate their body. Because you can get caught inside a mattress that may be too soft, obviously. The challenge, though, is you need to be comfortable when you're sleeping. And I personally cannot sleep on a firm mattress, so I don't know how you balance that necessarily. Even the height of the bed can be a question mark for some folks. I would like to see a bed that if you're sitting on the edge, the feet can touch the floor, but the knees are a little bit lower than the hips because it's easier to stand up that way. But I don't like to see a bed that's so high that your feet don't touch the floor until you slide off the edge of the bed, okay? Because that can be a challenge. Or a bed that's so low that it takes lots and lots and lots of work to get your body up and forward over your feet in order to stand up. I have heard that more satiny, silky sheets can help. You want to reduce friction, reduce the resistance to movement, but I don't have a lot of testimonial or knowledge on that. Has anybody used silky sheets? What is your assessment?
Wait.
Okay.
It works, she says.
It works, so you like it. There was another person too.
Great help.
Great help.
With like silky long underwear or something.
She's
Yeah.
saying you can combine with silky long underwear, but both. What is it?
Yeah, no, that's okay.
Then you may have
Yeah,
no friction.
because again, the idea is reducing the friction, and satiny, silky kinds of sheets can help do that. Okay?
She's going to need to move on.
For getting,
An adjustable bed, she's asking about an adjustable bed. Do you mean height adjustable? Or do you mean up in, the kind that gives you the head up and then the feet up?
Although
and the kind
balance
that gives you
exercise-
Say it up. Okay, she's trying to get us to move on. What can I say? Okay. You're just queuing it up. Okay, I understand. Okay. I think they're perfectly acceptable. They're fine. They're good. I mean, and in fact, sitting somebody up off the edge of the bed, if you can elevate the head of the bed, even 45 degrees, you've given them half of the distance to sit up. And that's a very, very excellent way to do it. Yes. Yes. All righty. All right. Okay, one more question. No more questions.
Comment, and I can stand up with this, I think everybody
Okay.
can give me comment, is the adjustable bed definitely works. Because when you can adjust that head and give the patient the remote and let them do it, so that they're comfortable with their height, and they can easily get out of bed and combine that with the handrail, they're on their own.
Perfect. Perfect. Yeah, you want to give your client as much independence as possible, but always within that realm of safety. So yeah, having them manipulate that themselves and having adjustable beds, which are everywhere nowadays. It doesn't even have to be a hospital bed to be an elevated bed. Alrighty. Let's look real quick at our next segment that we're going to pull up. This is getting up off the floor. So again, there are some points to look for. Alrighty. How you start the process, how you begin to transition through different movements. I like to call this technique crawling up off the floor. It's not the only way to get up, but it's a basic, practical approach to begin the process. I think one of the most fearful things about getting onto the floor is how you got there in the first place, which typically is, I fell down, right? And you may or may not have hurt yourself, but again, this is a fall that did not result in significant injury that we're dealing with. But we can also think about the floor as being, well, I want to sit down in my garden and do a little bit of weeding, or I want to sit on the floor and play with the grandkids. All right, so there are other opportunities to be on the floor, and I don't want you to fear the floor. I want you to be able to get up off of it. Again, the caregiver can assist by guiding the person. You will never, ever lift somebody off the floor. It's too risky. I would never do that without another person helping or without some kind of a mechanical lift helping. Alrighty. So this is a partnership of movement. As much as the client can do him or herself, go for it. When you need to assist, it's a guided assistance. It's not a heavy assistance. All right. We'll do a question right after this. Okay, so go ahead and cue it up and show it, please.
Although balance exercises can help reduce the risk of falls, individuals with PD will find themselves on the floor at some point. Once a fall has occurred, the first and most important step is to assess for injuries. If there are no injuries, then begin the process of climbing up off the floor. If you find yourself alone, get close to the chair, table, or walker. Sit and bend both knees up. Roll onto one side and bring one arm across the body to get onto hands and knees. Hold on to a stable object and rise to a tall kneeling position. Lift one leg forward and put your foot on the floor. Shift your weight forward and over the foot to bring the other leg forward to stand. If it is necessary for a caregiver to assist the process of coming up off the floor, then please note the following basic body mechanics being demonstrated. Once it has been determined that the individual has not been injured, then encourage and/or assist the person into sitting onto the floor and bend both knees up with their feet flat on the floor. Note that as both knees are being rotated to the same side, the caregiver is standing on a diagonal with the hips and knees slightly bent, to reach the individual without putting undue pressure on their back. When helping an individual to rotate his hips to a hands and knees position, the caregiver should squat to reach under the hip nearest the floor while reaching across the top of the uppermost hip. Maintaining the back in a neutral position, the caregiver gently guides the movement by extending his or her knees to move the individual's hips over their knees. Have a stable surface nearby for the individual to place his or her hands on and rise to tall kneeling. The caregiver can assist by placing both of their hands on front of each shoulder and guiding the person into an upright position. The caregiver reaches behind one knee in order to lift that leg forward for placement of the foot onto the floor. The caregiver then moves their hand onto the top of the knee to help the individual shift his or her weight forward over the foot to bring the other leg forward to stand. Note especially that the caregiver is standing on a diagonal with the hips and knees bent to make it easier for them to shift their weight forward in synchronicity with the individual's movements. The end point can be either standing or sitting, depending upon the individual's abilities and needs. Never pull on the individual's arms in an attempt to assist them. Never try to lift the individual from the floor by pulling underneath their arms. This can cause injury to both the individual and the caregiver.
I know not everyone is going to have a chance to do this, but we will have an opportunity for anyone who could stay after, the folks who signed up, I'm sorry, to stay after, to practice some of this. But again, it's all about guiding, controlling, moving your body, and never trying to move someone away from you, moving someone in synchrony with you.
Just to let you know, my husband has a very atypical form of Parkinson's that wasn't diagnosed till February. He has PSP.
Yes.
It's hard, yes.
Yes.
He had 11 falls. He falls backwards. He had 11 head injuries in 10 months that required an ambulance to the hospital. But you might want to know if you're caring for somebody who does fall, the paramedics do not charge you unless they take that patient to the hospital. I would call and say, "This is Carolyn again." Not really, but I could call them anytime he fell because it's 200 patients.
Very few activities of daily living
and they could come and pick him
occur.
up for me,
Yes.
and there's no charge.
That is
good
really
resource.
good to know. Yeah, I know one of my patients will come to class and she says, "I fell again," and obviously your face is a little messed up. But she lives across the street from a fire station. She just gives them a call. They come right over. They help her up. So what can I say? I mean, it's helpful. That's excellent. And again, call 911. I mean, that should be clear if there's any injury or challenge to your body. Okay.
And, looks like we maybe have one more right there.
All right, this is on.
What if the patient can't get on their knees, their hands and knees?
That's a challenge. Now, it's interesting that I was playing around. Maggie here is actually another physical therapist who's going to help me in a few minutes. I went on YouTube, and there's a couple of links. Well, it wasn't one of the links, but it was the very next one. It was called the MacGyver technique for getting up. I had never seen this thing. But if you happen to get into YouTube and call it the MacGyver techniques, I didn't even know. I mean, I'd heard about MacGyver as a TV show. Apparently, he's somebody who uses very novel techniques to do things. Basically shows a way to get up from the floor. You go all the way up to a surface like a sofa. You extend, push through your legs, extend your back until you're able to lay down on the sofa, and then just bring your legs over, and now I'm laying down. And it's like, are you kidding me? It's called a pivot point. It's really clever. So if you have a chance to look at it. But if you've got somebody with bad arthritis, if you have somebody with a lot of mobility problems, if they cannot go through the particular gyrations that we've discussed with this particular technique, I'm going to say ask for a consult. Tell your physician that I need to get a physical therapist or an occupational therapist involved because together we're not able to solve this problem and I need someone else to look at it. One of the primary reasons that a Parkinson's client is referred to physical therapy is because of a fall. So they need to be involved in a falls program, and within that program you will learn multiple techniques for getting up off the floor. Alrighty. Some of these are kind of the quick and dirty methods that work for the majority of the people, but nothing ever works for all. All right, so get some outside assistance with that one, please. All righty. Now, we're going to show sit to stand. Sit to stand to me is one of the most key elements that you and your partner can work with because it happens so often. So I want you to understand the basics, and for the few minutes that we may have after this video is over, I actually want you to get up and practice with me so that you will feel a little bit of what we're talking about.
Very few activities of daily living occur more frequently than does the process of standing up and sitting down throughout the day. Let's consider first how a non-impaired individual typically stands up from a surface, starting with the hips to the front edge of the surface, with the legs parallel to the ground and feet directly underneath the knees, feet parallel to each other. Lean forward in order to get the nose over the toes. Lift the hips off the surface, then push down through the feet to stand up tall. For an individual with Parkinson's disease, the activity of standing up and sitting down represents a situation in which a fall can occur. Start with good body alignment by making sure the hips are moved forward on the surface. Thighs are parallel to each other, and feet are underneath the knees. This can be achieved independently or with assistance as demonstrated. Bend through the hips to bring the trunk forward and over the legs. As this basic motion becomes more challenging, the individual can be encouraged to rock back and forth a few times to build up momentum as needed. As weight is being transitioned from the hips to the feet, then the individual can push down through the feet and stand safely. For someone who needs help with this activity, the caregiver has two options. Stand in front of the individual, supporting at the forearms or shoulder to help guide the body forward. The caregiver will need to rock backwards as the individual moves forward in order to allow him or her to partially stand. Having your feet positioned on a diagonal will help. In the second option, stand beside the individual with one hand on the shoulder or chest area and the other on the side or lower back area. As before, move forward and backward with the individual as he or she rocks in order to get the momentum for standing.
The video tries to show things quickly. It doesn't always give you a time to process it. That's why I say watch it more than once. But the key things are, sit close to the front edge of the chair. Alrighty. If the idea is we've got to get the upper body over the feet, why not give a person a head start? You need your thighs parallel and the feet slightly back underneath those knees. Alrighty. I'm just going to ask her to do this movement with a 4 count of come forward on 1, come forward on 2, come forward on 3 and lift your hips, and then on 4, let's have you stand up. Go ahead and sit on down for me, please. And notice that sitting down is just a reverse of standing, but it's a slow motion squat to sit. Again, shoulders have got to stay forward. Nose over toes. There's all kinds of jargon that you might hear that's very, very helpful. But one thing I would like to point out, we're just going to do number 3 real quickly, which is bring your head down toward the floor. If we're doing the rocking, and I'm asking her just kind of take this out of sequence, that point where she rocks forward to get the hips up, do you see what happened to the upper body? Did it start rising immediately? It went down. The body, the head goes down for the hips to pivot up, and then you finish the standing. So for me as caregiver, I'm going to stand on the diagonal, which means one foot's in front of the other. I've got my hands on the back of her shoulders just to give her some guidance. And we're just going to say 1, watch us together, move, 2, 3, come forward, and then stand up. All right? So I'm shifting from my forward foot to my backward foot to have her stand up, and then we're basically together. Sorry about that, right in the face, okay? The side view, hand on the chest, hand in the small of the back. We're going to do the same thing, but watch where my feet are. 1, 2, 3, you're forward, and then you're up on number 4. You can say all kinds of things that help you learn how to do that, and then sit on down and make sure that in the sitting down process, the shoulders stay forward. All right? We'll take 2 questions, but then before you go, I've got to ask you to do something for me. Okay, so there's one back over there.
Wait.
If you're in a really soft, like recliner or sofa, what are the hints? I know you move forward and come up,
Right.
but to get out of the cushioning.
To get out of the cushioning, let's get an elevated walk. No, okay, an elevated. Basically, you're going to walk the hips forward. I'm assuming that if it's a nice lounger that's got the armrests on it, we can bring the body over to the left. And even if necessary, the caregiver can then slide the right hip forward, okay? Now that it's forward, let's bring the hands over to the right and then slide the left hip forward. Maggie's doing it for me. And then come back to the left. So literally you're going to walk the hips forward. And it may not be something that the individual himself or herself can do without a little bit of assistance. Because I tell you what, those soft recliners can sometimes have a lot of friction in them. He's got a great suggestion as an alternative. Go ahead.
I was just suggesting putting a firm pillow on top of the soft sofa cushion.
That's definitely an option, as is it would give you more elevation to try to get out of the supports. I wonder if a firm cushion and or pillow might take away some of the comfort that nice little recliner offers. But yeah, you can definitely play with some kind of something that makes it easier to slide forward. But I have a feeling that some of the challenge is the depth of the seat. And if you change the depth too much, then you don't get to recline back the way you really want to. So you play around with those options, and yeah, that's a good solution as well. So push your chairs back from your tables, if you would, please. I wish we had more time for you to pretend to be a caregiver, but right now, all I'm really asking you to do is to go through that 4-step process of rocking forward twice, lifting your hips up, paying attention to where your upper body is, and then pushing down through your feet. So I need everyone to be sitting. Your hips are halfway forward in your chair. Make sure that you are far enough away from the table or your chair is turned so that you're not going to be hitting the table. And that's actually a segment on this video that was next, standing up from a table, so just FYI. So keep watching it. Okay, so anyway, ready? You're going to go forward on 1 and up, 2 and up. 3, get that head down, hips up, and 4, you're standing.
Betty, on those rocks, should their tushes be coming off the seats?
Not necessarily, but if they do come off the seat, there's really no problem with that. All righty? Because some people would say, oh, it's just naturally lifting, and that's a good thing. That's one reason why you rock. Okay? Helps overcome some of the stiffness, helps teach the body, oh, it's time to start moving again, and here's how I want to do it. If you yourself understand the movement that you're asking your partner to perform, it makes it a heck of a lot easier for you to guide the movement. And sometimes all they need is just a little bit of that boost. Because I will tell you, and I try to tell clients this too, you need to be more afraid of falling backwards than you are of falling forwards. Falling backwards is where the injuries occur, and we've already heard from one individual, the head injuries in particular. If you fall forward out of your chair, where are you? You're on your hands and knees. Big deal. Okay? But if you try to stand up and your toes are lifting off the floor, and you're starting to fall backwards, thank you, Maggie, she's good at that, okay. You're at risk. Forward, 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 and up, all right? Good deal, and I need to turn over the floor to
Yes, so please
Kathleen.
help me thank Dr. MacNeill.